Okay, so we're going to move into our first activity, which is our keynote. We're going to do a fireside chat. And it's funny because while I was preparing my cue card, my team just told me, you belong from another era. We're all on our phone, Joanne. So that's it. It tells my life. Okay, so long before dashboard and Zoom calls, our guest was already in the field of chasing outbreak, cracking cases, and learning the hard way that you cannot negotiate with a virus. Michael Osterholm is one of the world's leading voices on pandemics, on preparedness. Regents Professor at the University of Minnesota, Director of CDRAP, Center for Infectious Disease Research and Policy, Advisor to President, Diplomat, and Global Health Institution, and he is the author of The Big One. As a teenager, he got hooked on Bertrand Rocher, Annals of Medicine stories in The New Yorker, where epidemiology reads like a detective fiction. That spark turned into a career of real-world medical sleuthing, earning him the title that many now use, the medical detective of our time. How many medical detectives do we have in the room here? Raise your hand. In public health? Or is more than that? You're being shy. All right, okay, good. So Mike's book delivers a message that's uncomfortable and undeniable. The next pandemic isn't a question of if, but of when. And what will decide how we do next time isn't just only about the pathogen. It's about us, our choices, our courage, our willingness to act before the crisis and not after. Preparedness is not sexy, not glamorous. Preparedness is actually boring, as he said, but it becomes everything when there's a crisis. But it saves life. As Mike likes to remind us, hope is not a strategy and fear is not an excuse. Mike, when a virus is about to wreck and everyone's plan usually see it coming first, and we're very glad to have you here with us today and talk with us. Please welcome Mike Osterholm. Hello? C'est bon? We're going to do the Mentimeter. So get your phone, and the basic question is, do you have it, the question on? Oh, am I supposed to do something? Oh, you do it. Isn't it good? Kate is doing it. So do you think we are better prepared for the next big one? That's an easy question. So we're going to take couple of minutes to answer. We do that at the beginning and we do that at the end. And we see how Mike has managed to change your mind. Bon? All right. Okay. Good. So there's going to be a Q&A, and then I wanted to start. That's the book. It's a hard copy. This is what is going to be on sale, and it's going to sign book afterwards. But when I read and started this book, then it started with, nothing was ready for the war which everyone expected. Tolstoy. So, Mike, our pandemic, our modern version of that?
Well, first of all, let me just say it's a real honor to be here with you. Thank you. When I look out across the room here, I can't tell you how much it means to see you engaged in this topic area, since it, to me, is one that we are surely not appreciating on a global basis. Today, one of the things, if I do nothing else to share with you, is that, you know, I'm not sure that I know a lot more about pandemics than anybody in this room here. I think maybe what my perspective is, I bring to you the sense that, yes, they will occur again, But the most importantly, we do not nearly enough use creative imagination to imagine what the future could be. One of the reasons we got in trouble with COVID right from the get-go, our first weeks we handled it as if it was going to be a hurricane. It was going to come through and be deadly, but it would blow through quickly, and soon we'd get into recovery. When in early March of 2020, I made recommendations that we had to prepare for the next 3 years, and I actually went so far as to say I could expect to see over 800,000 deaths in the United States in the next 18 months. You know where I got panned? I got panned from my colleagues. I got panned from some people in this room because of being hysterical or being, this. And let me just say that, to follow with Tolstoy's very important quote, our job is not to scare people out of their wits, it's to scare them into their wits. And I think that's today, if we have any theme, is how do we get people to understand what the future is going to be? And there will be that future.
Thank you. You say in your book that COVID was more like a training run and not the main event. So then tell us, why did COVID bring the world to its knee without actually being the worst case bio threat?
Well, when we look at events in public health through history, I look at the issue of what happened following 9/11 in the United States with the anthrax situation. And here it was, 21 cases of anthrax, and what risk was it for the real world? But yet it brought our country to its knees in many ways. You can look through the course of any number of crises that have occurred, which in of themselves were not what I would call worldwide defining crises. A good example, and Joanne knows this one well, was with Ebola in 2015-17 in Africa. Was that ever really a risk for the whole world to be engulfed in an Ebola outbreak? No, but it was very important to that part of Africa. We isolated ourselves in very many ways in terms of what was going to happen. And one of the things I think that we really need to work on is, in fact, what are those things that really are going to be the disasters for the future? And concentrate on those and understand what those mean and keep in mind all the other things that are going on, still needing to respond. But we have not learned really very many lessons from COVID. And our country was probably the worst, the United States, at recognizing we're spending all of our time trying to argue, was this a lab leak or was this a spillover? And we're avoiding the inevitable, difficult question of what lessons should have been learned. So I think, to comment, Joanne, I think that one of the challenges that we have today is understanding that. I'm an old distance swimmer, an English Channel swimmer. And my mindset was, if I had a 4-hour training swim, I had my mind on that one in a certain way. But if I was doing my 12-hour long swim today, I had a different mindset. But it was very important to me to understand, because if I hadn't understood at 12 hours, I'd have given up after 4. If I hadn't planned for that. And so I think one of the things we need to do today is also help prepare us, not just to recognize a pandemic, but how do we respond to it and know that we're going to be in this for the long haul and get our colleagues to understand the same. If we had done that, I think we could have avoided some of the challenges early on in the pandemic where people thought that we were lied to them. We didn't tell them the truth.
So it's not really a question of lethality or speed or immune escape. It's a mix of everything.
Yeah. Well, and in the book I talk about this. The only agents right now I see potential for a pandemic are a virus with wings. And that notably is influenza and basically coronaviruses. I don't see anything else. Surely Ebola could. Remember the famous Richard Preston work on the hot zone and so forth, which was all about an outbreak of a virus, an Ebola virus in monkeys in Reston, Virginia, and it was airborne. So I don't want to dismiss that, but I think the key thing is, and I know I saw this here, and I just want to offer a friendly amendment. You cannot prevent a pandemic. Understand that. You cannot. Once a pandemic is out the door, and that means in the very most localized area of the world, means could be hundreds of cases only, it's gone. And our job is to detect it early, of course, and to try to do what we can to limit the impact. But we aren't not going to do that. And I've said this over and over again with so many of the infectious agents I hear, well, we got to prevent the next pandemic. Our job, I think, is to concentrate on detecting it. And then how do we switch into pandemic mode once we know that it's happening?
Good. And as we have some tools, I'd like to hear more from you about universal vaccine. Is it the magic bullet? Is it possible, knowing how hard it is, to develop flu and dengue vaccine? Do you think really that we have cracked the recipe for a vaccine that will cover against families of viruses?
Well, again, to talk about all the different virus vaccines, we could spend a whole week in that conference. So I think it's an important question. Our group has focused specifically on influenza and coronavirus vaccines. And we actually have established the roadmap, the landscape and roadmap for both those vaccines, where we've brought together the world's experts with both coronavirus infection and influenza infections and vaccine work to understand what is the next steps to get to what you would call a universal vaccine. One also that is durable in protection, as well as recognizing a variety of different variants of that particular virus, influenza or a coronavirus. I don't think we're there yet, but what I'm very concerned about is right now what's happening in the United States is we're having an erosion for the very basic of vaccines. Mumps, measles, rubella, diphtheria, tetanus. We don't even have to worry about new vaccines. One of the things that I was involved with was helping in the Biden administration to leave a legacy request for that government to basically invest $500 million in transferring the mRNA technology to flu. If you know, today, most of our flu vaccine still in this world is made in inbreeded chicken eggs. And if we were to have a pandemic of flu tomorrow, we would basically may be able to make enough vaccine that would be of moderate protection in 1 year to cover only about 20% of the world's population. On the other hand, if we had an mRNA technology flu vaccine, we might be able to make enough vaccine and at least the same protection, if not more, to cover the whole world in 1 year. The difference between those two experiences is literally millions and millions of lives. So what did our country do? We withdrew all that support for that vaccine research. We did. And so I'm concerned that we're actually backslipping quickly, if not falling backwards, with our vaccine investment. Last week, you heard both Moderna and Pfizer announce that they were no longer going to be doing infectious disease vaccine work, basically, which was a huge, huge issue. And so I think what our job is right now is just to preserve what we had to try to get us to vaccines. Do I think we can come up with better vaccines? Absolutely. I'm actually quite excited by some of the things we're seeing right now in vaccine research. And let me just point out on the COVID issue and vaccine with coronaviruses in general. I had the opportunity to work on SARS, something near and dear to many Canadians' hearts, back in 2003, because at that time, after 9/11, I had split my time between helping the Department of Health and Human Services in the United States following 9/11, and I was there for SARS. I served as an advisor to the royal family of the United Arab Emirates and was actually on the Arabian Peninsula working on MERS when it emerged in 2012, and then actually was in Samsung Medical Center in Seoul in 2015 when an individual brought MERS back to Korea. And, I had a sense really of how incredibly challenging these kinds of vaccines or these diseases were and the vaccines we'd need. But what was striking to me at the time was I kept saying, thank God this is a limited airborne transmission, meaning we had super spreaders that surely hit a lot of people, but generally speaking, people were not that highly infectious. Well, now look at where we're at. You have a virus like COVID that has a case fatality rate in a country like yours and ours of about 1.5%, highly infectious. Well, we've uncovered literally within the last year viruses in nature that have the ability to be transmitted like COVID and the ability to kill like SARS and MERS. Imagine if our pandemic hadn't been a 1.5% case fatality rate, but it had been a 25% case fatality rate. If you think we had a problem with the last pandemic, that was just child's play compared to what was going to happen with this other. So I do think that the investment in these particular vaccines is huge. I think the return on investment is there. I'm worried because not only are we seeing the loss of support for vaccine research as such in the United States, but basically the European Union and the countries of Europe in the past were major supporters of vaccine work, which are now diverting their funds to defense. If you look at the GDPs, what's happening in Europe, we're not seeing the investment we need. So the bottom line is, yes, these vaccines, I think, can be a reality. Will they be a reality? It's up to us.
Thank you very much. Let's switch gear a little bit and talk about airborne reality. During COVID-19, few of us wash our groceries, even bleach it, I think, I've heard, while the virus was floating in the air. You've called that the willful blindness in your book. What does it really mean to apply the precautionary principle when a new virus appears?
Well, first of all, one has to understand the dynamics of airborne virus transmission. We like to think of this concentric circle of approach in life. And for some infectious diseases that are largely transmitted via droplets, that's true. But we wasted billions of dollars in Canada and the United States in the last pandemic, putting up plexiglass shields and little signs saying stay 6 feet apart. Let me give you an example of an airborne infectiousness. Some years ago, we had an outbreak of measles in the state of Minnesota. We had not had indigenous measles in our state in the previous 4 years, but the Special Olympics had come to town for the world. And the opening night session, all the team players, the coaches and so forth, marched into this large Metrodome in the Twin Cities, and kind of a right field garage door, marched in and went through the entire infield, outfield, and filled the entire level below. And at that point, also 64,000 Minnesotans, largely, came and were in the stands, like a big baseball field, and watched this opening ceremony. Well, unfortunately, there was a young boy from Argentina that was just breaking with measles that sat on home plate, basically, was where it was, for 3 hours during the ceremony. Well, we had an outbreak among the players and the coaches and so forth. We also had some cases in Minnesota residents who did not have any contact with each other, who basically had not traveled, and their only experience was they had been to the opening night session. When we actually uncovered these, we looked at the airflow currents that came out from the fans behind home plate that blew air out. The air outtake for that air ended up being 427 feet away, up in the upper right field corner, where in fact at that time baseball players on steroids couldn't hit home runs. And all the people in that section that basically had not previously been infected or had not previously been vaccinated all became cases. Think of that. That's what an airborne virus can do. And let me just say, we have done virtually nothing in either United States or Canada to impact on HVAC improvement today. Our buildings are still the same that they were before the pandemic. So airborne transmission really is important to understand how you can have widespread transmission and why that's there. Next time you're walking down the street and you smell somebody smoking a cigarette and you realize it's 35 feet in front of you but downwind, that's an aerosol. And so the challenge with that is that therefore when a new virus emerges, we don't know if it's airborne or not. The precautionary principle says, until you know differently, treat it as if it were, okay? And that, I think, is where we get into it. And I know this has been a major debate in Canada. It's been a major debate in the United States. Is this airborne or not? I will just say, and happy to spend the next 7 days defending this, these viruses are airborne, and they are really a very, very challenging transmission issue to deal with.
Thank you. I must say, I just want to remind people that actually he's doing a great job in that Q&A because he landed here at 4 a.m. this morning. So we're very grateful that you're wide awake and you're participating to this Q&A. And we got a question beforehand from someone who is obsessed about air transmission, and she basically said, what needs to happen for airborne transmission to be recognized as the main mode of transmission for SARS-CoV-2? Why, we're still not enacting that properly. We still have surgical masks instead of having respirator N95.
Well, first of all, let me just pay tribute. One of the people that had a wonderful influence on my life and my career was Don Lowe. Many of you in this room know Don Lowe. He was an amazing man. Don Lowe was such an important figure during the SARS outbreak here in Canada and how that was handled. And I remember having a conversation one night with Don and saying, why do people not get this airborne issue? And Don says, you got me. I have no idea. It's just so clear, plain, and obvious. And so I think that we've had this challenge. And some days I think we'll look back on this maybe 100 years from now, and we'll put Semmelweis, we'll put John Snow, and we'll put the airborne transmission people from the world today all in one category. Nobody would believe you. Nobody would believe you. And I think that's the real challenge, because in fact, if you're really looking at what can we do about transmission, putting up another, millions and millions of dollars of plexiglass or, signs on the floor to stay 8 feet apart are meaningless. And we have to have people you may not be aware of this, but there's actually been 3 studies conducted now in looking at the use of surgical masks as to the prevention in surgical site infections. All 3 of them basically had half the patients randomized to the surgeon wearing a mask and half nothing at all. Guess what? In all 3 studies, the rates of post-surgical site infections were identical. Surgical masks are a costume. They're not really there unless it's a droplet issue that they may surely limit some elements of transmission. So I think it's time that we move on. And basically the organizations deal with occupational exposures they've come out with very clear and compelling ones. There have been, WHO, it was a major challenge for several years to get them to acknowledge the airborne transmission. And I can't tell you for the life of me, Joanne, why. The data are so compelling. And I look back on Semmelweis and I say, man, I get why that hand washing thing was such a problem.
We are a slow learner. So, this is me who's asking this question, because I remember that you co-author a paper in 2015 saying that you could not rule out airborne transmission for Ebola. Yeah. You mentioned it again in the big one. And I was wondering on which evidence you came to that conclusion, and why was it so controversial?
Well, it still is controversial, and let me just say that I'm not telling you today that the primary mode of transmission of Ebola is in fact airborne. I don't think the data support that. But what I am telling you is we have enough examples, and I gave you the hot zone example with Richard Preston, and the fact that these primates at the center in Reston, Virginia, all died basically from an Ebola virus that was transmitted clearly via the air. In this paper that you're referring to, that I was the first author on, we had 20-some of the leading world's experts on Ebola virus on this paper. And we recounted the number of laboratory experiences we'd had, in which the Canadians, by the way, provided some critical data for, in which we again had clear evidence of transmission between primates who had no other contact than could possibly be airborne transmission. And we had outbreaks. I think that the issue of also what we see on the ground, in limited ways, we have this anecdotal information that in families there were individuals who had clearly had no contact with a body fluid that anybody recognizes, but they were in the presence of what would have been potentially an airborne environment with someone who was infected. So what I'm saying is beware. What if in fact one day we wake up and damn it, it is actually being transmitted widely by airborne transmission? And, look at the difference between what happened with SARS and MERS, and then all of a sudden along comes COVID. In my book, 2017, I published a book, Deadliest Enemies, What You Need to Know to Deal with the Coming Bioterrorist Catastrophe. And in that book, I lay out a 3-chapter series of what a pandemic might look like, which is very much elaborated on in the big one. But one of the chapters was SARS and MERS, a harbinger of things to come. And we weren't prepared for that. We hadn't thought through, well, what if in fact this suddenly is widely transmitted? What would it look like? And so I think for me, the Ebola issue is one to say, don't discount it. Okay, don't just dismiss it. I'm not saying it's happening like that right now, but I think it's there. And this is what people are uncomfortable with. They don't like uncertainty. They want certainty. Tell me, is it or is it not? I'm saying, I don't know. And if I could leave you with one other message today, I think the most important message I've learned in my career, humility is everything in information sharing with the public. It's absolutely critical. Tell people what you know and what you don't know. And when you tell them what you don't know, you tell them what you're going to do to find out what it is. You know, I wake up almost every morning as I'm sitting on the side of the bed and I say to myself, man, I wish I could know today what I'm going to know 6 months from now.
We wish as well. We know that in movies, somehow presidents listen to experts. In real life, it's not the same. You said that biological reality beats political reality. Tell us, how do public health leaders keep influence when politicians don't want to hear bad news? How do you deal with that?
Well, first of all, let me just point out that if there was ever a time when the term expert has become to mean nothing, it's now. Because there are a lot of experts out there that I have no real expertise from, as we would look at it from a science perspective, as to what they're saying or how they're saying it. And unfortunately today, we have many leaders that rather than being wise and getting counsel from a number of different sources and then trying to understand what does the intersection of all that advice mean, they pan or cherry pick individuals that support their position so that they then can be right. And this is a real challenge we have. And I think it also even gets to the fact of what we accept. You know, a week ago, we had basically the leading person at CDC, who is in the United States, who is medically trained, who is there now, made the comment that these measles cases are just the cost of doing business on a global basis. Well, I don't believe that, okay? And I do remind people that, you know, in this case, I'll just say on measles, I keep telling people, please watch Canada, please. 5,000 cases and 40 million people this year. The United States has 340 million people. What could it look like in 2 or 3 years? And boy, people don't want to hear that because you're not the expert giving them the wrong information. And so to answer your question specifically, I don't know the answer to this because it is challenging. You know, we are in a place today where it's not just who is an expert, but what are the topics that need to have an expert to comment. Again, I look at our country, we are so fixated on was COVID a lab leak or was it a spillover that we don't talk about anything else. We're not talking about getting prepared for the future. We want to go back and relitigate elections. We want to go back and relitigate what happened at the expense of not knowing. So I think all you can say from an expertise standpoint, and I might add, I've had the good fortune, I've served in every presidential administration since Ronald Reagan. I was involved with HIV/AIDS.
You're that young.
Yeah, yeah, I just approaching my 52nd year in the business. And I served as a science envoy for the State Department during the first Trump administration. My job has always been to call balls and strikes. And that has been, I think, a very useful approach. But it's becoming less and less tangible because today we fractionate off into our experts, your experts, those experts. And I don't think we have a good definition for what an expert is today.
Right. You've been called Bad News Mike. You've received threats. Just wondering, what kind of advice would you give to scientists who are speaking truth in a hostile environment? I'm saying that because I know here in this room, many of us have spoken and have on news, and I've received threats. I've received some of them. Any advice? Because we're a bit in the same team.
This is a tough one, and I say that in the sense that, in my 52 years in this career, I've surely taken on a lot of difficult issues. But this is very different. And it's one where if you look at the everyday news, another shooting, somebody else does something, somebody targets somebody. And, I don't want to be careless and ignore that possibility, but I can't let those threats run my life. every day I sit at my desk in good Zoom meetings and bad Zoom meetings and watch a 12 by 16 inch electronic picture frame on my desk go by with pictures of my 6 grandkids. And that's all. And I never have to wonder why I'm in this business. Then I get a threat several years ago that was deemed legitimate by the law enforcement, where somebody wrote, "Shut the F up, I know where your daughter works and where your grandkids go to school." And all of a sudden I thought, man, this isn't just about me. You know, I might be taking in a risk of my own life and my own safety, but it's affecting my family. This is a challenge. I don't want to ignore it. I don't want you not to think that that could be there. But I think the one thing that we have going for us is that it still is focused on a few people who are more public. So if you're doing the hard work of public health in the trenches, the likelihood that you're really going to be threatened and something happen is very, very, very small. But it doesn't mean for some of the people that it couldn't be a real risk. You know, Tony Fauci is a very dear friend and colleague of mine. I'm going to see Tony tomorrow. And, you know, here's a man who's had so many threats that were deemed legitimate that you have to do that. But do I see others in his immediate circle at risk? I haven't. And so I would urge you to stay the course because of those grandkids I talked about. We need in public health never to forget. We're not here for ourselves in a sense. We're here for our future. And I think that's an important message. So yeah, do worry about safety, but I don't think it's your safety that at this point for most of you need to worry about.
Time is flying, but I had this question because I cannot not talk about it. So in your recent Osterholm update, you discuss how increased immigration enforcement activity, including encounters with ICE, has been linked to families delaying or avoiding to go to healthcare in Minnesota. Just tell us, you know, what happens when fear drives people away from healthcare? What are the impact on public health?
First of all, the whole concept of public health is largely based on volunteerism and trust. I can't get somebody to do certain actions or not by demanding they do it. You have to convince them why it's important. You know, we don't have a policeman at every street corner in our country at the stop sign so that when you come up, they can explain why you need to stop. Okay? We voluntarily stop because we've been taught that that's important. Why is it important? So you don't have a collision, somebody gets hurt badly. I think that public health is very much that same way. We have to bring people together to help them understand why the action we're recommending is in their best interest. And it's in the interest of their family, their friends, their colleagues, etc. And so I think the challenge we have today is, in fact, how do we engender that trust in people who just automatically believe that you're lying, you're not truthful. And you can't, debating them makes no difference. It doesn't help. In fact, it entrenches them. How do you deal today in a medical community where having a discussion with your patient that the patient has every intent of talking for the next hour about why their child should not be vaccinated, you've got 20 minutes, 15 minutes maybe at most to talk to these people. So that part's a challenge. But the challenge that you're also referring to is what we're seeing in Minneapolis, children who come in with ruptured appendix because for the last 4 days the parents were too afraid to bring them in because they were black or brown and they're afraid they're going to be targeted, which is happening. When you see the video of a woman who has severe injuries and in terms of her previous lifetime and largely able not to walk and was on her way to a medical appointment for her this situation, and she was literally pulled out of a car where they actually broke the back window to get into the car and used a knife to cut the seatbelt while she was struggling to explain to them, I'm just caught in this traffic, I'm just trying to get to a doctor's appointment, but she had the wrong skin color. You know, that's the thing that deters people from seeking medical care because they're afraid to go out. The number of home births has gone up substantially because people are afraid to come to the hospital to deliver. Well, we know what that means. And so there is a collateral damage here to the medical care and public health systems that is very, very real. And, you know, I may not feel it because I'm an old white guy, okay? So, you know, they're not likely to target me. But I know far too many people who are being targeted right now that this is not a inappropriate response for people to say, I don't want to leave my home. But then what's the consequences?
Thank you very much for your thoughts on this. I'm going to skip all the nice questions I've prepared, and because time is flying, and I want the audience to ask you a few questions. But let's do a rapid fire round. I know you like them, so I ask you something, and you respond as concisely as possible.
Oh boy, if you ask my kids, that's very difficult.
I know, I've heard about that. I've heard about that. Okay, biggest pandemic myth.
The issue of airborne transmission.
That's a good one. We give you a big 10 on that one.
Thank you.
Okay.
Thank you. Hey, listen, when Joanne says that, that's a big honor. Trust me. I'd fly all the way from Minneapolis just to hear that, okay?
The most underrated public health tool.
Huge. The toll?
Tool.
Oh, tools.
My French
Trust.
accent.
I think it's trust. Everything else, whether it's vaccines, whether it's public health actions, whatever, it all comes from trust.
Okay, one thing that the public get right about pandemic.
I'm trying to give you the best one, okay? I think it, as much as there was a great deal of pain, angst, and suffering because of real disease, but also because of the politics, I saw some of the most heroic public health activities in my entire career. People who braved all the challenges, who spent mega hours through snowstorms and others vaccinating people, etc. I could not have been more proud in many ways of the people that I call colleagues.
Nipah in India. Are you worried or you're not worried?
Oh, well, I'm always worried, but it's like, how hungry am I? I'm very hungry, I'm not hungry at all. I'm a little bit hungry. I think, again, what sets me off is this a potential airborne pathogen? Okay, because then it changes the dynamics. Even if it's a milder infectious illness, but now it's likely to infect lots of people. So I think that's, to me, the big piece, airborne transmission, and then we go from there.
So this is my last one because I want to finish on a positive note. What gives you hope that next time we will do better?
I hope that I'm not optimistic that between now and the next time we're really going to learn lessons from the COVID. I think we are moving on beyond that, and we're going to say goodbye. I hope that in the period of time of the first couple of weeks of the next emerging pandemic, we do go back and we do deep dives quickly into what worked and what didn't work in COVID. And I think that's a really big issue. A good example is I got panned royally. I wrote an op-ed piece in the Washington Post in March of 2020, early on, and said, whatever you don't do lockdowns, do not do lockdowns. And people said, what do you mean? Aren't you a public health guy? And I said, do you realize this is going to be a 3 to 4 year experience? And everybody was thinking, again, like the hurricane. It'll 6 hours, 12 hours, and we can go into recovery, okay? And I said, are you really locked down for 3 years? And what does it lockdown mean? And I said, rather, we should be doing snow days. And people looked at me like, what the hell, a snow day? And I suggested at the time that we have every hospital post every morning their bed census. And the public health community, the medical community, the public could all see that. And if they start to get above 100%, 110, 120%, where people are in the hallways or in garage stalls and parking ramps, etc., I said, at that point, we're asking people voluntarily. They can see the numbers. Please help us let this come down. So it's like riding the waves, okay? Get it down, and then we may be back to you again. That's the kind of thing I think that we could learn quickly and say, okay, 1, we're in this for a long time. Two, there are things we can and can't do that are going to make a difference now in year 2, 5 years from now. So I think that to me is the example of what could be great, is for us to go back and learn that.
I hope so as well. So Mike, you spend your life preparing us for the worst case scenario, and I don't think you leave us afraid, you leave us more capable. Thank you for your clarity, your honesty, and your courage. Thank you for your world service, 52 years. Guys, round of applause for that.
Yeah, I'm going to take the prerogative, I guess, because I'm here. Having you say that's remarkable, because when I sit next to you, I feel so small, and in a good way, because of all you've done and all you've around the world. You know, I'm a drop of water. You're the St. Lawrence Seaway. You know, I look at that and I think to myself, thank you. I mean, you're one of my heroes, and I hope you know that, and I hope that the kind of work that you do now is built upon your whole career of tough, dangerous, difficult situations and not giving up. And so, thank you.
Thank you. So we have 5 minutes to take questions from the crowd. So we welcome people. We'd be glad if you have concise questions, because we can take a few. So any people would like to ask a question? There's a hand in the back.
This may be a simplistic or question, but do you think, was there a point at which COVID could have been stopped and not become a pandemic?
Thank you. Not a simple question, a complicated question, but a really good question. And my answer is no. Once it's out, it was out. And I think that's what I try to cover in the book, you know, a scenario where it emerges in Somalia and Kenya. I might add that in the book, all of that information about the camps, the airplane flights, etc., all is real. We've vetted that with all the people from Somalia, Kenya, etc. So, yeah, once it's out, it's gone.
Can you put back the genie in the bottle, I guess? Mm-hmm. Okay. Any other question? Yes, please.
Thank you so much for sharing with us. So Joanna asked you what gives you the most hope. I'm curious as to what gives you the most dread in terms of preparing for the next pandemic, and what can we do to address it?
It clearly is our lack of commitment to the future. And what I mean by that is that I'm so excited. Why did I come here today? Because first of all, if Joanne asked me to walk across broken glass barefoot, I would, okay? But more importantly, to see this kind of effort here is so important, because it doesn't let us forget that there will be another pandemic. It doesn't let us off the hook of preparing for that. And so what gives me hope is groups just like this, you know? There was, I just a very quick story. Harry Chapin, late great balladeer, there's a couple in this room old enough to remember him, was dear friends with Pete Seeger, another great balladeer who basically protested Vietnam, et cetera, et cetera. And one night, Harry asked Pete, he said, Pete, you know, when you do all this work with this stuff and et cetera, he said, does it really make any difference what you do? And Pete looked at Harry and he said, you know, Harry, I don't know. But I can tell you, when my head hits the pillow, I know I spent the day with the good people. You know, I'm sitting in this room and I'm watching the good people.
Thank you so much. I think we're going to stop on this. Mike, this is the break right now, but before we do that, we do the last Mentimeter. We want to know if Mike convinced you that we are or not better prepared. So, on your mark with your phone. Oh, les gens voient pas le...
Sorry.
You need the, I think people need the QR.
It's the same number up at the top. Yeah, it's 5
is your bet? What is your bet? It's going to increase. Better prepared. Are we good? Everybody got the QR code? Ooh. So there's less voter this time. Well, we're going to need to invite you again.
Or not.
We thank you very much.
Thank you. Thank
it's
you.
going to be break time. Mike's going to be signing book just outside here. And then as well, we're going to resume it at 11:15. Thank you so much. Be back in the room at 11:15.